Good evening, and welcome to tonight's Men's Health webinar with Dr. Etai Goldenberg. Tonight, Dr. Goldenberg will cover the signs, symptoms, and treatment options for stress urinary incontinence, and then discuss the same for erectile dysfunction. You can ask questions anytime during this presentation. Simply navigate to the chat feature by moving your mouse in your laptop or touching the screen on your smartphone or mobile device. Find the chat box, type your question in, hit submit, and we will address those questions at the end of the presentation. You will also hear from a patient this evening. And without further delay, I'd like to introduce Dr. Goldenberg.
Thanks, Mike. Appreciate the introduction. Thank you all for tuning in. Like Mike mentioned, the goal for today's talk is to address men's health issues, focusing mostly on erectile dysfunction as well as stress urinary incontinence. Here you go. So the idea of this talk is to have an open dialogue. Like Mike mentioned, we will be able to record the seminar as well as you can address questions halfway and then at the end of the presentation. Here's a picture of me. So my name is Etai Goldenberg. I'm one of the urologists at Urology of St. Louis. I've been here for 9 years. Prior to that, I did my urology training at WashU in St. Louis. And then I went to New York and did a fellowship in men's health, focusing on male sexual health, male incontinence issues, as well as reproductive issues. It's really what I like to do and take care of men with these specific issues. And that's really been the focus of my career the last 9 years or so. So this is what I focus on. And I really enjoy doing these presentations and taking care of these patients. So I appreciate all of you for tuning in. I want to take this talk really in two halves. The first half we'll talk about stress incontinence, and second half about erectile dysfunction. So to start off, talking about stress incontinence, what is it, who has it, and what are the causes? So when you make urine, when a man makes urine, if you up here, the kidneys make the urine then fills into the bladder. The bladder is a muscle. So the muscle that allows stretching and storage of urine. When you're not trying to urinate, the prostate sits here, and then below the prostate is this area called the external sphincter. Those have compression on the urethra so that when you cough or sneeze or exercise, you're not urinating. And then when it's time to urinate, your body does two things. One, it pushes the muscle of the bladder to push the urine through. And in addition, it relaxes the muscle inside the prostate and relaxes this external sphincter to allow the urine to pass through the urethra. When someone has incontinence, which is the involuntary loss of urine, there are multiple reasons why you could lose urine. That's either one, if there's stress incontinence. Stress incontinence means that you cough or sneeze or lift something heavy, and there's an additional pressure on the bladder that pushes the urine through that area. There's also something called urge incontinence. Urge incontinence is when your bladder squeezes more than you want it to. So if you have an overactive bladder or this feeling of I have to go and I have to go right away, the bladder can squeeze too much and the urine can leak past those muscles. Some men do have a combination of mixed incontinence. I apologize for the noise. Apparently they are doing construction at my office tonight after we closed. So I hope you can all hear me. Focusing today on stress incontinence. Stress incontinence, like I said, is the leakage that you have when you cough, sneeze, lift something heavy, and therefore there's pressure in the bladder, and that pressure then allows the urine to go past the muscle that's there. This most commonly relates to a man that had prostate cancer treatment. So what happens, which I'll get to in a minute, is that when the man's prostate's removed, you only rely on the external sphincter muscles because you had your prostate removed, and therefore you only have the muscles of the external sphincter to allow you to be protected from leakage of urine. So when you cough or sneeze or lift something heavy, there's less muscle to protect you. Other risk factors include radiation therapy, enlarged prostate surgery, or neurologic issues. So as I mentioned, when a man has prostate cancer and has a radical prostatectomy, which is the most common surgery for a man with prostate cancer, approximately 70,000 are performed per year. The prostate, which is this gland that sits right in here, is removed. That means an incision is made here where the prostate connects to the bladder, and here where the prostate connects right above the external sphincter. The nerves that run adjacent to the prostate are peeled off the prostate in order to protect those nerves. And then, as you see, the nerves remain here, and then the urethra is sewn back together to the bladder. Most men do have leakage immediately after their prostate is removed, but with time, that muscle, that external sphincter strengthens, and only about 10% of guys have significant leakage about a year after their prostatectomy. So what are the options for a man that has leakage after prostatectomy or any type of stress incontinence? Number one, behavioral modifications. So like I mentioned, if you exercise or lift something heavy, that's more commonly when you leak. Planning restroom trips, emptying your bladder all the way before you go and play golf or play tennis does help reduce how much leakage you have. Limiting how much fluid you take in, how much your bladder fills before those activities also helps. Pelvic floor physical therapy has been shown to help a lot. So like I mentioned, in that first year after the prostate is removed, it's very common to have to strengthen that external sphincter. So either doing pelvic floor physical therapy, which is working a physical therapist, or working at home and doing Kegel exercises and strengthening those muscle areas really have been helpful to reduce stress leakage. Coping mechanisms like pads and diapers don't cure the problem, but are a way to manage it. If you do leak a fair amount, I always remind myself and my patients that there is an expense to not having an intervention for stress incontinence, especially the cost of having a significant amount of pads, especially if you leak more than one pad per day. So if you're a man that had your prostate removed or you had prostate surgery of some sort and have the stress incontinence, there are two very highly effective procedures that have been shown to be helpful to have a long-term fix for leakage. One is a male sling. A sling is a procedure where a piece of mesh is placed under the urethra to help support and elevate the urethra, giving that muscle group that's left behind some extra support. This is a really nice option for guys with mild to moderate incontinence. Or there's a procedure called an artificial urinary sphincter. This is a procedure where you replicate the function that the sphincter was supposed to be doing. This is for men that have either failed to sling, men that have severe incontinence, or men that have had prostate surgery and radiation therapy. And I'll talk about these both in a little bit more detail. If you look here on this picture, this is the male sling procedure. A male sling is a piece of mesh that's placed here underneath the urethra. If you look here, the sphincter mechanism, the sphincter that's left behind after the prostatectomy is shown here in blue. When the sling is placed outside the urethra and then tightened by going around and through the muscles in the pelvic area, this is pulled up and then gives this extra support. And you can see that those blue lines are longer, indicating that there's a better positioning and better work that's performed by the sphincter. This is really a great operation for men that leak. What I say is 1 to 3 pads in a day, maybe up to 1 to 4. The idea being that you have to have a sphincter that works already, and what you're doing is you're giving it extra support. This is a minimally invasive outpatient procedure. Some of my patients stay overnight and some of them go home the same day. Once you're all healed up, you don't have to function with the device. Hopefully your continence is restored and you don't have to interact with the device like the artificial sphincter, which I'll get to in a moment. The recovery period is most patients either go home the same day or stay overnight. You have to take it very easy for 2 to 3 weeks. The sling does have to heal into place, and so you are limited that you can't lift anything heavy. You can't bend or squat or do physical activity with high exertion for 6 weeks after the operation. The other option is an artificial urinary sphincter. So this is the gold standard. It's been out for almost 40 years. This is the device that replicates what the sphincter mechanism that you had internally used to do. This involves a cuff that sits around the urethra, a pump that sits inside the scrotum, and a pressure regulating balloon, or this valve here filled with fluid that sits in the lower abdominal area. What happens is the cuff causes permanent pressure on the urethra until you press the button on the control pump, opening up the urethra and allowing the urine to flow. Here is a quick video showing how this device works. A patient has the device installed. Once it's activated, you squeeze that pump that's in the scrotum, opening up the valve up here, letting the urine flow. The valve stays open for about 2 minutes or so, letting the urine drain, letting the bladder come out, letting all the urine out of the bladder, and then closes back up again until it's next time that you want to pee. Artificial sphincter is a very highly satisfactory procedure. Over 90% of patients would be are happy they had it done, but there is risk associated. One, this is really for men that have had a weakened sphincter or have failed the other therapies. It's a device that's placed inside the body, and so there is interaction that you have to have with it your whole life. There's a possibility that device can break down or stop working. The average device lasts around 10 years or so. This is a procedure that's usually my patients stay overnight. They go home the next day. The device is not activated until about 6 weeks after the operation. So you do continue to have leakage as you did before until the device is turned on. And after the device is activated, the goal is to have 1 pad or less per day. Excuse me. Like any procedure, like I mentioned, there is risk. With either a male sling or an artificial sphincter, we are placing foreign material inside the body, so there is a risk of those becoming infected. There's the possibility that we improve the continence too much, that you have urinary retention, that you don't empty your bladder or don't empty completely, possibility that you still have some leakage after the procedure, or the possibility that additional procedures would have to be done. Most men that have a sling or an artificial sphincter placed are prostate cancer survivors, and normally Medicare and other insurance providers do cover these procedures. Prior to having the surgery performed, we would verify with your insurance company to make sure that you have full coverage, or at least know what your out-of-pocket expenses would be. There's more information. I know this is a brief overview of these devices, but at fixedincontinence.com, you can definitely have more perspective and more questions answered. And then really to focus on what's the next step. If you're bothered by male stress incontinence, most men that had their prostate removed already have a urologist that they are in contact with and follow up regularly. It's reasonable to start by discussing with the urologist that you're already seeing, and say, I have incontinence, and I want to address some of the long-term and permanent changes that can be done. A prostatic urologist, someone like me, and a few others in the area, really specialize and focus on these types of treatments. And if you are interested, I'd be happy to see you for an appointment. So overall, stress incontinence is a known side effect of prostate cancer. For surgery, approximately 1 in 10 men will have significant long-term incontinence after their prostate's removed. There are lots of short-term coping mechanisms, but a sling or an artificial sphincter can be a permanent solution for male stress incontinence. So that's kind of my short discussion on incontinence. Mike, are there questions that you want me to address before I move on to erectile dysfunction?
So just a question about the next section of the presentation. So let's keep going.
So just keep going.
Yep.
All right. Perfect. Okay. Can you see? Okay, Mike, everything's good?
Looking great. Yep.
Perfect. I shall continue. Okay, so changing gears slightly, but similarly, I'm going to focus in a kind of similar flow about erectile dysfunction and the treatment options. Luckily, the construction stopped here, so it's quiet again. Erectile dysfunction, who has it, what are the causes, and what can we do about it? So what is erectile dysfunction? So I think every man has their own description of what erectile dysfunction is for them, but for me, I would say it's really the persistent inability to achieve or maintain an erection that's firm enough to have sexual activity. How prevalent is it? It's really, really common to have erectile dysfunction. It's 1 in 5 men over the age of 20, and it's over half of men over the age of 40. And I think it's really eye-opening to realize, how common this is. Half of men, if not more than half of men over the age of 40, do have some degree of ED. In simple terms, when I think of a man getting an erection, I really think of it as a 4-step process. It starts with really having the right desire for an erection. So that starts kind of more in your head. That's having in the right stimulation, the right situation, having the right amount of stimulation. Part of being in the right mood or having the right amount of libido and sex drive is having enough testosterone. Once that signal leaves your brain to go down to the penis, you have to have normal nerves, normal blood vessels that send that signal down to the penis. And on the level of the penis, what happens? The penis itself is made of 3 tubes. It looks here like 2, but on the top here, these pink one, these are the erectile bodies. There's 2 side-by-side erectile bodies. These have a small artery and then lots of veins inside. Underneath is the urethra, which is the tube you urinate through. When a man gets an erection, the artery in the middle of these 2 tubes, of these corporal bodies, opens up, bringing blood inside, and then the veins collapse in order to keep the blood from exiting the penis, giving a firm erection until you're done with sexual activity. What are the most common causes of erectile dysfunction? As I mentioned, the way the penis fills with blood is the man gets an erection is by the penis filling with blood. So a vascular issue or blood flow issues are really the most common reasons why a guy will have problems with ED. Additionally, diabetes, which can affect both nerves and blood vessels, are very common reasons. Medications that can be taken to lower blood pressure or other medications can affect erections, and prostate and pelvic surgery are also very common issues. I'm going to speak briefly about each of these kind of risk factors and comorbidities that affect erectile dysfunction. So diabetes is very common. About 15 million men in the United States have diabetes. Men with diabetes do have earlier erectile dysfunction than the non-diabetic man. And in addition, men that have diabetes have a less robust response, less of a response to pills that are given into other treatments for erectile dysfunction. Men with diabetes, what are the common issues that they have is if the amount of time they've had diabetes, the worse their glycemic control, also the presence of peripheral neuropathy or microvascular disease puts them at higher risk of having erectile dysfunction. Focusing on heart disease, if you look at this diagram, which I think is very nice, the penile artery, like I mentioned, there's the 2 that run into the penis are about 1 to 2 millimeters in size. These blood vessels are what brings blood into the penis in order to get an erection. Comparing that size of blood vessel to the blood vessels that are in the heart that allow blood to flow into the heart, they're about a quarter of the size, 3 to 4 millimeters for this coronary artery disease. So any man that has a history of heart disease, any man who says I had a stent to be placed in those coronary arteries, or they had a stent placed in their neck and their carotid arteries, they almost certainly have narrowing of the blood vessels that are in the penis, as those blood vessels are much smaller. Things that can affect heart disease, which also can affect erection issues, include diet, physical activity, weight loss would help. Smoking can affect both blood vessels and erectile function. So low testosterone, as I discussed before, testosterone is the hormone that is released from the testicle and helps a man with sex drive and desire and libido. The timing when a man has low testosterone is really similar to the timing that many men do have erectile dysfunction. And those are men about 4 out of 10 over the age of 45. And the risk factors are also about the same. Men that are overweight, men that have diabetes, or that have risk factors for heart disease or vascular issues like high cholesterol and high blood pressure also influence low testosterone. When a man has low testosterone, they often feel tired or run down. They have decreased muscle strength, decreased concentration, Oftentimes they say that they feel tired, lethargic, difficult to get in the mood. They have a decreased libido and also erectile dysfunction. There's lots of options out there for a man with low testosterone. So number one, when you see your doctor and you're worried about having low testosterone, it's a blood test to look for low testosterone. It has to be a blood test that's performed twice before in the morning time, usually before 10 a.m. to really prove that there's low testosterone. We don't really decide based on one blood test, but you have to have at least two that show a low level. And there's lots of therapies that are out there. And more, there's newer options for testosterone replacement. And those include gels that you put on your shoulder or other parts of your body daily. There's patches you can put on daily, injections that can be done weekly, pellets that are placed under the skin every 4 to 6 months. And there's some new oral therapies that are also available. Excuse me. Prostate cancer treatment. So this picture is very similar to the one I showed before when we were talking about urinary leakage. When the prostate is removed, an incision is made above and below the prostate, removing the prostate, and then the urethra is sewn back to the bladder. The nerves that run adjacent to the prostate, like I said, that are pulled off and pushed to the side in order to remove the prostate, these neurovascular bundles are what bring the nerve stimulation from the rest of your body to the penis. When there's an injury to these nerves, your penis doesn't know that you're being stimulated, that you want to have an erection. So it's very common for a man to have erectile dysfunction because of problems with those nerves after their prostate's removed. It ends up being about half of men after they've had prostate surgery have worsening erections than they did before their surgery. In addition, men that had radiation therapy, a different form of treatment for prostate cancer, also about half of those men do have issues with erections after their radiation therapy, and men that had both therapies have a higher chance of having erection issues. Peyronie's disease. So Peyronie's disease is a process where scar tissue forms in those corporal bodies, or that sheath that brings the blood into the penis. When you have usually a small trauma and you're genetically predisposed to getting plaque formation, what happens is you can develop this fibrous plaque. A fibrous plaque, or this Peyronie's plaque, what happens is becomes less elastic than the rest of the penis. So when you get an erection, most men have curvature. Most commonly it's upward, but can be to the right, left, or downward because the penis doesn't stretch in the area where that plaque is. This can cause difficulty with sexual intercourse. Often it does coincide with a man having erectile dysfunction and also have curvature issues. Now there are newer and different treatments for Peyronie's disease. Peyronie's disease can be treated with non-surgical options like stretching exercises or traction devices that can be ordered and worn on the penis in order to stretch plaques out. There's one FDA-approved medicine for Peyronie's disease. This is a disease called Xiaflex. Xiaflex is a collagenase. It's injected into the plaque to help break it down over multiple series of injections in the office. If Xiaflex doesn't work, or if you're not a candidate for it, there are surgical options, and those include either a plication procedure, which is shortening the opposite direction of the curvature in order to achieve a straight erection, incising or cutting the plaque and then putting a graft in, or doing a penile implant. A penile implant is the really great option for guys that have erectile dysfunction and significant curvature. All right, so that was my quick overview of the most common causes and reasons why a man can have erectile dysfunction. Now I want to focus on what some of the treatments are. So if you fall in the category where you have bothersome erectile dysfunction, it usually does make sense to start by talking to your primary care physician or to your family practitioner, whoever you kind of are most comfortable speaking with if you're interested. More and more primary care physicians are comfortable writing for pills and starting the workup, checking for testosterone levels, and seeing if there's an underlying cause for your erectile dysfunction. If you continue to have issues, or if you want to jump right to it, you can see a urologist. Most urologists should be able to treat most forms of erectile dysfunction, but a prosthetic urologist, someone like me and some other some other doctors in the area are specialized and really do a lot more of these implant surgeries, which I'll talk about more, and really are more comfortable treating the host of treatment options. So what are those treatment options? Those include, excuse me, pills, which I will talk about in more detail. Most men have heard about these pills, which include Viagra and Cialis. Wave therapy, which has been highly discussed recently, which is an off-label therapy for allowing more blood to flow into the penis. Injection therapies, which is a small needle that goes into the penis and allows the blood vessels to dilate. A urethral suppository, which is a small pellet that's placed into the urethra, dissolves and allows the blood vessels to dilate. A vacuum erection device, which is a cylinder that goes over the penis, pulling blood inside, and then a ring is placed in order to maintain the erection. Or a penile implant surgery, where the inner parts of the penis are replaced with cylinders that are controlled by a pump, and then you squeeze this pump in order to get an erection whenever you desire. So in more detail, I'll talk about the pills. The Viagra, Cialis, and many of the other competitors have been on the market for a number of years now. And like I mentioned, many primary care doctors are happy to start the treatment of erectile dysfunction with pills. The way these work is you take the pill and it makes the blood vessels in the penis more sensitive, allowing those blood vessels to dilate more with stimulation. Approximately 60 to 80% of guys do have a nice response to it. And so in my mind, unless you have a reason why you can't take the pills, which most commonly are taking nitrates for chest pain or other medications that can't be mixed with these medicines, this tends to be the first stop. Pills do work well for many men, and even if it's not a long-term solution, will help men for many years. Side effects, the different medicines do have different side effects. With Viagra, most commonly men get flushing or stuffy nose. With Cialis, most people do get some low back pain, which are the most common side effects. Again, if you take any type of nitrate or nitroglycerin, you need to talk to your doctor just before starting any of these PDE5 inhibitors for erections. Low intensity shockwave therapy, like I mentioned before, this is a off-label therapy. There's newer studies that have shown that if we do this shockwave, which is somewhere about 6 treatments in the office, about 20 to 30 treatments, these small pulse waves go to the penis and allow the blood vessels that are there that have narrowed to become more robust, forming a repair to the damaged blood vessels, and also hopefully creating newer blood vessels, something called neovascularization. What's nice about this is a very safe therapy. The side effect profile or the risk of harm from low intensive therapy is very low, but it is an off-label therapy, so there have not been very good long-term studies, and currently the FDA has not approved it. This has really been shown to be most helpful for guys with what I would call mild to moderate erectile dysfunction. If you have some decrease in your blood flow to the penis, this therapy may help you. Men with severe erectile dysfunction or men that have erectile dysfunction because of nerve injuries, usually diabetes or prostate treatments, tend not to do as well with the shockwave therapy. A vacuum erection device is a hollow tube that goes over the penis, and then by placing it against the belly wall, and you form a seal, and then you can press a button here or squeeze a pump that pulls the air out of that tube. This forms a vacuum. The vacuum then pulls blood into the penis and allowing for an erection. Once the erection is achieved, you place this ring on the base of the penis to maintain the erection. In my experience, 80 or more patients are able to get a firm erection with this type of device. That said, the satisfaction rate is rather low, as many patients complain that the ring can be tight or uncomfortable. Side effects can be discomfort from that ring, blocking your ejaculation, or discomfort or lack of sensation in the penis. A urethral suppository, this is a pre-packaged apparatus that needs to be refrigerated. It deposits a small pellet into the urethra. This pellet is then dissolved over the course of 5 to 10 minutes and then is taken up by the penis and allows blood vessels to dilate. Lots of men don't love this. A, it's rather expensive, and B, it's uncomfortable. More commonly, I'll admit, we talk about doing injection therapy. Injection therapy uses a very similar mechanism of therapy, but instead of pushing into the urethra, we give you a tiny needle that's injected into the side of the penis. This delivers the medicine right into the penis. So instead of a pill that you take that has the medicine go through your entire body, the injection is delivered right to the penis, so you don't have any side effects through your whole body. You just have an erection, hopefully. The idea is the medicine goes in, allows the blood vessels to dilate, hopefully within 5 minutes or so, and gives an erection that should last 30 to 45 minutes or so. Lots of my patients are pretty satisfied with this therapy, but there are risks and side effects. Most commonly, if you have fear of needles or discomfort with the injections, there is a risk of having scar tissue form at the area of the injection site. In addition, you have to make sure that you do this injection appropriately and that you don't give yourself too much of the medicine. Too much of the medicine can result in a prolonged erection that won't go away. If an erection lasts for more than 4 hours, that's considered an emergency. For that reason, when men are taught how to do injection therapy, they come into my office, I teach them how to do these shots and tend to do well with them. And finally, I want to talk about a penile implant. So a penile implant is a device that replicates or what the natural erectile function used to be. What we do is we replace the inner parts of the penis, those two cavernosal bodies, with two tubes that go inside those cylinders. Those cylinders are filled with saline or salt water, and there's a pump that sits inside the scrotum. You squeeze the pump, and in the three-piece model, there's a little reservoir of fluid that sits in the lower abdomen. And what you do is when you squeeze the pump, you're shifting the fluid from the reservoir into those cylinders, allowing for an erection. That erection can remain for as long as you want it to be there until you press a release button, the erection goes down. This is a surgical procedure, so there is risk when a device like this is placed. The most common thing we worry about is infection. That said, infection rates used to be much higher back in the day. The newer devices now are coated with antibiotics, and our fear of infection has really decreased because we have devices now that are coated with antibiotics. We give antibiotic therapy before, during, and after the operation, and overall infection rate sits about 1%. Other risks are mechanical problems, pain afterwards, needing for repeat surgery or mechanical problems down the road, or the risk of just having a general anesthesia for having a surgery like this. There are different models of an implant. A spectra or concealable device is 2 cylinders without a pump that are placed inside the penis that you can bend up and bend down when you want to have sexual activity. An ambicor 2-piece device has a pump and then the cylinders without a reservoir. And the most common device we place has the 3 pieces, the reservoir in the lower abdomen, the pump in the scrotum, and the cylinders. You can see that this device is yellow because this is the one that comes coated in antibiotics. Oh, sorry, that's what it says here, that the AMS 700, the 3-piece device, it comes coated with antibiotics to reduce that risk of infection. So, if you look here in this diagram, as you squeeze the pumps, fluid fills the cylinders, allowing for an erection. You can maintain that erection for as long as you desire, and then to have the erection go down, you squeeze the release button, and then the fluid escapes back into the reservoir until next time. Oh. Sorry, this crashed. Can you still hear me?
Yep.
Okay. I'm trying to get this to start back. Technical difficulties, sorry. Okay, this should start. I tried to sneak past this part before and it backfired, so I'm not touching it. Okay, so in this patient, you can see the pump sits here inside the scrotum. In order to shift the fluid, you can see he's pulling this pump up and holding it steady with one hand and squeezing the pump with the other, therefore shifting the fluid into the two cylinders. As you pump, the more you pump, the more fluid you're shifting in, making the erection firmer. As you can see inside the body, the device is concealed and really not visible unless you know it's there. In order to turn the device off and shift the fluid back to the reservoir, you can see a little button right there. Press the button that opens the valve back up and allows the fluid to escape back into the reservoir. In order to get all the fluid out, I think the patient will do it here in a second, you squeeze the penis in order to get the remainder of the fluid out of the penis to get a completely flaccid penis. Penile implant is a very highly satisfactory procedure. In my experience, over 95% of patients, 95% of their sexual partners are happy that they had it done. That said, there is real risk associated with the penile implant surgery. That includes about the 1% risk of infection, which is slightly higher in men that are diabetics. There is a risk if you have pain after the procedure or mechanical failure as time goes on. The average device lasts about 10 to 15 years. It's designed to be a permanent solution for erectile dysfunction. It's spontaneous because it's inside the body. There's a high patient, a high partner satisfaction rate. It typically does not interfere with any type of orgasm or ejaculation. It's been out for over 40 years and nearly 500,000 of these implants have been performed. Most insurance companies do cover placement of a penile implant. That said, before we did a surgery, we would verify with your insurance to make sure you have coverage or know of any out-of-pocket expenses that you would have. Boston Scientific does a really good job helping us to make sure that we know what a patient would have to pay and if they do or do not have coverage for a penile implant surgery. And then overall, kind of taking an overview of all the options, there are many options for men to treat erectile dysfunction. Those include injections, pills, wave therapies, and penile implant surgery. There's not one right answer for you. I think it's important to go talk to your primary care doctor, talk to a urologist, or see someone like me that specializes in prostatic surgery to discuss. All right, I tried to be thorough and not take up too much of your time. I'm really lucky to have Cliff here to talk about his experience. So I'm going to turn over to him and then answer questions at the end. Does that sound all right?
Great.
There you go.
Good evening, everyone. What you're going to hear just briefly is this journey that my wife and I took from the time I was diagnosed with prostate cancer and ED through today. Basically, 19 years ago, I was diagnosed with prostate cancer, and I decided to have my prostate removed. And as a result of that, needless to say, I ended up with ED. I did try the pills, and unfortunately, even though the pills were taken correctly, the pills gave me terrible, terrible headaches. They were like migraines, and I just could not function with them. I've tried all three brands at that time, the Levitra, the Cialis, and it just did not work. So we went ahead and got a vacuum erection device, used that. We've used that for about 3 months. I will say it did work. Unfortunately, there's a couple of things that are very unnatural about it. Number one, it's very non-spontaneous. You have to stop and pump it up. And it seemed that the more you were excited about having sex, the longer it took. And by the time you got back to the bed, she's asleep. But basically, the reality was that when you put the band on, the constriction band, your penis does turn cold, it turns blue, and truthfully, it does not look very, very normal. Taking the band off is not a problem. Getting it up the shaft. I had major issues taking it over the head of the penis. And after about 3 months, I gave that up. And at that point, we just stopped having relations. And for 2 years, I was in a very, very, very bad funk. I was depressed. I didn't know what to do. Our intimacy between us was gone. There were times when she thought maybe I was seeing somebody else and I wasn't interested in her anymore. And that was the farthest from the truth. And so I will tell you, one of the things that's very important at the very beginning of your working with ED is include your partner in everything, at the doctor's offices and everything, so they understand what's going on. Because ED is not just a male issue, it is a issue for both male and female. I finally got an invite to a presentation like this, and I learned about the Muse, the little pellets. I learned about the injections, and I learned about the inflatable, excuse me, penile prosthesis. And my wife and I talked about it. We decided to get the prosthesis. The day after my 60th birthday, I did the second best thing I ever did in my whole life, and that was have the surgery for have the implant done. The implant lasted me 14 years. It never failed. It was with me all the time. The thing that's nice about it is if you travel and things like that, you do not have to worry about keeping the medication on ice or anything like that. It's there when you want it. It's also, the other thing is it truly brings back intimacy that you really don't think you have lost, but you really have when you do not share sexual relations with your partner. People ask me a few questions, and that is, well, what happens when you go through the airport? Does it go off? And the answer is no, it doesn't go off at the airport. They ask me if it has anything to do with not being able to have, excuse me, not being able to have any type of scans, either MRIs, CTs, PET scans. The answer is no, it doesn't affect any of that. But the biggest thing is they ask me, well, what about urination and or bladder issues? And the answer is nothing. If you need a cystoscopy, not a problem whatsoever. I am now, it lasted 14 years. 2 years ago when I was 74, I had it replaced with a new one. I'm happy to say that it works great, just as good as the first one, if not better. And the only thing I would say above and beyond that is you don't necessarily, what you saw with at the live presentation is you don't necessarily need to use your whole hand to blow it up. 2 fingers seem to work fine, your thumb and your middle finger, and you can actually get much more flaccid than what is shown in that presentation. So at this point, I will turn it back over. Mike, if you have questions, Dr. Goldberg, I'm here. And so